Hey everyone, so we are going to start with the viral infections of the oral cavity, and at the back I have an illustrative table with me which is going to depict what are the two kind of viral classifications which we can look into. So if we talk about the classification of the viruses, these viruses can be divided into DNA viruses and they can also be divided into RNA viruses. And the DNA containing viruses are either single stranded, which is this one strand, or they can be double stranded, which are your couple of DNA strands which are in us as well. The RNA viruses can be positive strand and can be negative strand viruses as well. Now these viruses can be classified according to their shape as well. If we take a look, sometimes these viruses can be in the form of helices and they are called as helical viruses, and sometimes they have this three-dimensional symmetry which is called as the icosahedral shape. Now the helical virus classical example is that of the filovirus family, and the icosahedral virus family can be seen in the adenoviruses. The complex viruses, the classical example is that of a bacteriophage here. And then what we can see is that those viruses sometimes can be enveloped and sometimes these viruses can be naked as well. Whenever there is an enveloping around the virus, you can see the viral content has an envelope here. So this envelope can be made up of the protein content, it can have lipids, proteins, and it can also have glycoproteins as well. So this I'll talk about more in detail when I'm going to talk about the HIV virus. Right now it's a brief introduction as to how we can classify these viruses. So we have DNA viruses and we have RNA viruses. Now you would be saying, sir, this is too much, that's too much information, how can we simplify it? So obviously we can simplify it and we'll just remember the DNA viruses by an acronym which is happy. So just remember that DNA viruses are very happy, okay? That's the acronym which we'll remember. H, we have written happy over here and we're going to start with the H. So H basically stands for the herpes virus family, and the herpes virus family is a complex family which we will discuss in detail. The next H here is the hepadna virus family, and the most common member of the hepadna virus family is hepatitis B, which we will not talk about now, we'll talk about in microbiology. Okay, so we have H herpes, H hepadna, and A is for the adenovirus family. Now the adenovirus family, there are not many important diseases, so we are not going to talk about much in detail about this. The next we have the P, and we have papovavirus family. So we have herpes, hepadna, adeno, papova, and then we have the parvovirus family. And finally, the last P here is the pox virus family. So you can see the spelling of happy is not correct. It is not H-A-P-P-Y. It is H-H-A-P-P-Y. Just remember that Y is just an accessory. H here is for the herpes. The next H is hepadna. A is for the adenovirus. P is for the papovavirus. The next P is the parvovirus. And finally, we have the pox virus, and this constitutes the family of the DNA viruses. So now let us start talking about this DNA viruses in detail. The first family, do you remember the happy HHA, and we had this triple PY. So the first H was the herpes family, and this is where we are going to talk about the herpes family in a lot of detail because it is asked in the MCQs and it is also important from oral medicine perspective as well. So let's start with the herpes virus family, and in this family we have 8 members. You can see 1, 2, 3, 4, 5, 6, 7 and 8 members, and all are called as human herpes virus family. 1, 2, 3, 4, 5, 6, 7 and 8. Okay, so just remember that HHV1 is your herpes simplex 1 and HHV2 is your herpes simplex 2. HHV is the human herpes virus family. So nothing difficult here. You will remember the HHV, which is the HSV1, and the HSV2, which is the herpes simplex 1 and the herpes simplex 2. The HHV3 is the varicella virus, and this is where we'll make an acronym for 345. What acronym are we making for 345? It is VEC, V, E and C. Okay, so HHV3 is V, which is varicella zoster virus, and HHV4 is the E here, which is the Epstein-Barr virus, and the HHV5 is the C here, which is the cytomegalovirus. So you will just remember the herpes simplex 1, which is the HHV1, the herpes simplex 2, which is the HHV2, and for 345 we are going to make an acronym which is VEC. V is varicella, E is Epstein-Barr virus, and C is the cytomegalovirus. Now, the HHV6 family here is also called as the roseola family because it causes a disease which is called as roseola infantum. Roseola means red, so it's a red rash which is seen here, and HHV7 is very similar to the HHV6. And finally, we have the HHV8, which is associated with the Kaposi sarcoma and associated herpes virus. So just remember, 1 is HSV1, 2 is HSV2, 3, 4, 5 is VEC, HSV6 is roseola, which is roseola infantum, and the 7th is very similar to the roseola, and the 8th is the Kaposi's sarcoma family, and this actually gives us a brief table and an introduction about this human herpes virus family. Now let us take a detailed look into one by one each. And firstly, what we are going to talk about is the herpes simplex virus. Okay, the first thing which we are going to talk about is the herpes simplex virus, and as already talked about, this herpes simplex virus can be HSV1 and it can be HSV2 as well. So this basically spreads predominantly through infected saliva or the perioral lesions. Now we are talking about HSV1. If I draw a simple man here, okay, let me just draw this person, and he's very upset because let's say he's suffering from herpes. And what we'll do is we are going to make two divisions here. One is above the abdomen. So the HHV1 generally affects above the abdomen, and then we are going to take HHV2, which generally affects here, which is below the abdomen. So the two strains, HHV1 generally is related to the head and neck region, spreads approximately till the trunk and doesn't go below the abdomen. HHV2 generally is associated with the abdominal regions. So when we are talking about this HSV1, which is the HHV1, human herpes virus 1 family, this mainly is going to spread through the oral route. So this is going to spread through the saliva or through the active perioral lesions as well. Somebody, let's say for example, has this herpes inside the oral cavity and is speaking th th th. So some droplets will come out, and those droplets can be thrown onto the other person, and the other person can generally get affected as well. So this basically generally adapts to the oral regions, the facial regions and the eye as well. The HHV1 adapts closely to the oral, the facial and the ocular area, which is the eye region. Now when we go inside the oral cavity, it is going to affect the pharynx, it is going to affect the intraoral sites, it is going to affect the lips, the eyes and basically the skin above the waist. So do you want me to write it down? Okay, I'll write it down. It is this HHV1 is going to affect the intraoral sites, which can be your pharynx, okay, it can be other intraoral places, and then it can be the lips, it can be the eyes, and basically it is the skin above the waist. Now when we are going to talk about the skin here, when we're going to talk about the skin here, one important thing you have to understand is that this virus generally affects the ectoderm. So this primarily affects this HHV1 and HHV2, they primarily affect the ectodermal areas main. That is generally an ectodermally affecting virus. Okay, so as we've seen, these areas are the ones which are involved more frequently. Now, when we are going to talk about the infection in detail, and let's say a person is initially exposed to the virus. Now, the person who is initially exposed to the virus will not have antibodies. Obviously, let's say this person, and let's say this is the bad virus, okay, right? So, yeah, the virus is happy because he's going inside this person, and when this virus is going to travel inside the person, the virus will act like an antigen. That means the body will make antibodies. But since this is the first exposure in this person, this person has never ever been exposed to the herpes virus, this infection would be called as the primary infection. Okay? This infection is generally called as the primary infection. So a person who is suffering from the primary infection is not going to have antibodies, and generally the first exposure happens at a very young age. When you are young, that means some older person will come to you, oh my baby, touch your cheeks or whatever, and talk to you and will give you a gift, and that gift is that of the virus. So generally the first exposure to the virus occurs at a young age, and this is seen in children. And generally what happens, these children are most of the times often asymptomatic. Okay, this generally does not cause any severe disease, and what happens, the virus generally is taken up the nerves. You see, I am showing you a disease here, and this disease is herpetic gingivostomatitis, which is the primary infection seen in very few children with exposure. Most of the children have had an exposure, but then they are asymptomatic. So that's what we have to remember, that the primary infection generally is asymptomatic. So the primary infection, what we see here is generally it is asymptomatic. And then what happens, this virus travels retrograde and lives in the ganglia. Okay, now the ganglia I am not going to draw here, I am going to talk about when I am going to talk in varicella in detail. Just remember, this virus now will travel retrograde via the ectoderm or via the oral areas. They will go back and they will start residing in the ganglions. Now generally there are two houses here. The HSV1 has a house which would be somewhere above the waist. Okay, HSV1 would be residing here above the waist, and the HSV2 has a house which is below the waist. So what are the houses or what are the ganglia where the HHV1 live? So the HHV1 lives in the trigeminal ganglion. Okay, this ganglion we have studied in detail in anatomy, if you remember. Okay, so the house of HSV1 is the trigeminal ganglion, and the house of the HSV2 is the lumbosacral ganglion. Okay, lumbosacral ganglion, and that's why it is going to reside below the waist, and when it will travel via these pathways, it is generally going to affect in those areas which are below the waist. I'm talking about HHV2 because HHV1 was generally affecting you above the waist. Okay, so now what happens after the primary infection, when the virus has traveled inside their homes, which are either the trigeminal ganglion or the lumbosacral ganglion, they live there normally. Okay, they live there latently. That means they are not affecting, but yes, they are generally present. Okay, so now what happens when the virus is residing in the ganglion, it is generally the viral DNA which lives there in the ganglion. Always remember that this is the virus, and yeah, let me just draw the virus. Okay, this is the virus, and the virus is going to have DNA as well. generally the virus doesn't live inside the ganglion. It is the DNA content, it is this DNA content which is going to live in the trigeminal and the lumbosacral ganglions. Okay, ultimately when it is going to reinfect, it is later on again going to convert into the virus. So what we are seeing is, when this virus is living latently inside the ganglion, the DNA of the virus lives latently inside. Okay, now if we talk about the clinical features, all primary infections are occurring because of contact with an infected individual, and generally when you are first exposed, the first exposure, the incubation for the virus is, for the primary infection, it is 3 to 9 days. Okay, so that's the incubation for the virus. It is approximately 3 to 9 days. So most of the people are asymptomatic, but then what happens to those who are actually infected? So those who are actually infected is said to have a condition which is acute herpetic gingivostomatitis. You can see, okay, let me just write the name here. What is the name? It is acute herpetic gingivostomatitis. Okay, so as the name suggests, it is acute herpes. That means it is occurring in roughly 3 to 9 days, and it is gingivostomatitis. Itis is inflammation, and gingiva and stoma. Stoma is the oral cavity. So we have the inflammation of the gingiva, which you could see in the previous figure. We have this inflammation. You can see these inflammation around the gingiva, and you can see that this virus is also affecting the attached areas or the attached mucosa of the oral cavity, and the gingiva is a part of the attached mucosa. So we have gingivo and stomatitis. You can see this inflammation, you can see these vesicles which are generally formed here with the disease. Okay, so that's what we are seeing, and generally these herpetic gingivostomatitis infections are seen between the ages of 6 months to 5 years. So this generally affects those children from 6 months to 5 years. This is the main time. If the patient is not asymptomatic, then he or she is going to suffer from this acute herpetic gingivostomatitis. The peak prevalence of occurrence when you are actually meeting other people or when you are being exposed with the virus is 2 to 3 years of age. So the peak basically occurs at 2 to 3 years of age, and the onset is abrupt. That means it occurs very fast, and then what happens, because of this exposure, there is lymph node enlargement as well, and there is anterior cervical lymphadenopathy. Now the body starts to realize, oh, okay, what does the body realize? That this fellow has come inside. Now when this fellow has come inside you, the body generally has a very severe acute lymphoid reaction, because of which the neck lymph nodes, because it is going via the oral cavity, the cervical lymph nodes enlarge, and cervical lymphadenopathy is seen in these patients, and then the antibodies are formed by you. Okay, so after the primary infection, along with it, the antibodies are formed. You have a severe reaction, fever is there, and plenty of fever, 103 to 105 degree fever F. That means around greater than 38 degrees centigrade fever F fever is generally seen. If you measure it in Fahrenheit, it is 103 to 105 degree F. The patient also presents with nausea, anorexia, irritability, and sore mouth. You can see these vesicles which are formed here on the tongue as well, and these vesicles are a hallmark of the HSV1 infection. Now, oral medicine point of view, I would like you to differentiate between a vesicle and a bulla. Okay, so now the question arises, what is a vesicle and what is a bulla? So simply put, both are the same. That means both are fluid filled areas. Okay, both are fluid filled. The only thing is that the vesicle is smaller and the bulla is larger. Both of them have fluid filled in it. Okay, both of them have fluid filled in it, but the vesicle is smaller. That means it is less than 5 mm in size, and the bulla is generally greater than 5 mm in size. So the difference between a vesicle and a bulla is only the size. Vesicle generally is small blister in which there is intraepithelial fluid which is accumulating. Fluid is generally accumulating around the epithelial origin. I told you these viruses generally love the epithelial areas, so the epithelial areas become swollen and they become fluid filled. When they are smaller in size, they would be called as vesicles, and when they are larger in size, they are called as bulla. Okay. So what happens is, I was at the clinical features and I was telling you that these patients suffer from anorexia, irritability and sore mouth as well. Now initially what happens is, the affected mucosa develops numerous pinhead vesicles. We can see these pinpoint vesicles, these classical vesicles which are being seen here. Okay, now let me rub them off so that you can appreciate them. Okay, right. So when I rub them off, now you can appreciate these vesicles as well. Right. So initially what happens is, these numerous vesicles develop and they sometimes coalesce as well. That means you have these small vesicles and they can combine as well. So the vesicles later on can combine and result in the formation of bullae as well. Okay. So now what happens, this generally can affect both the fixed as well as the movable mucosa. You have enlarged painful lesions which are reddish in color, and generally you can see these vesicles which have developed here around the oral cavity. These resolve in approximately 5 to 7 days. That's what happens. Generally they resolve in 5 to 7 days if the lesions are mild to moderate. In severe, the healing time is longer, and in severe cases, the healing can take place for up to approximately 2 weeks. Now what we'll do is, we'll also take a look at the histopathological perspective. And as I had told you what is going to happen here, let me just draw the difference between the epithelium and the connective tissue. So the above layers here, let's say this is the epithelium, and this here is the connective tissue. So where do you think the virus is going to lie and affect? Yes, it is going to affect the epithelium, and epithelium is going to be filled with fluid, and this is where the vesicles generally are appreciated. So this we can see here are the epithelial areas. Now generally what happens here is that the normal epithelium has these connections between two cells. This is a third cell. So this is how they are laying down normally. But when the virus comes here, these cellular connections are broken and they become little bit roundish in shape. So these generally lose their shape as well, and this degeneration of the epithelial layer is called as ballooning degeneration. Okay, what is this degeneration called as? It is called as ballooning degeneration. Okay, and these cells, when they lose their shape, they are also called as Lipschutz bodies. What are Lipschutz bodies? These are eosinophilic structures in the nucleus. Okay, so when we'll take a look, we'll have these Lipschutz bodies, which are eosinophilic bodies inside the nucleus. Okay, so this is the nucleus and we have these red bodies here. And what are these called? These are called as Lipschutz bodies. So we have ballooning degeneration here of the epithelium. Lipschutz bodies are also present, and then what happens is intraepithelial vesicles are also seen. In fact, what we can see is that we can see some granular bodies here. Can you see a cell here? if you see this cell, it actually has these granular bodies inside it. Okay. Now, we have to remember that the granular bodies, because of the viral infection, are called as Cowdery type A bodies. Okay. We have Cowdery type A bodies. Now the question arises, there are some other bodies as well, and those bodies are called as Cowdery type B bodies. And now you will ask me, sir, what is the difference between Cowdery type A bodies and what is the difference between Cowdery type B bodies? Both are intraepithelial because the virus ultimately is going to affect the epithelium. So these bodies are going to be seen in the epithelium only. Now the Cowdery type A bodies are granular. So if I draw a body here and it has granules, then I will call it as Cowdery type A. Okay, and this is classically seen in your herpes simplex virus and the varicella zoster virus. Where are Cowdery type A bodies found? They are seen in HSV and they are also seen in varicella zoster virus. Now the Cowdery type B bodies are amorphous. So what happens is, within the cell and the nuclear area, when these are seen like these amorphous areas, then they are said to be Cowdery type B bodies. And the question arises, where are Cowdery type B bodies seen? They are seen in polio. They are seen mainly in poliovirus, and they are also seen in cytomegalovirus families. Okay, so we have to differentiate between Cowdery type A and Cowdery type B bodies. Now there are multiple conditions in which Cowdery type A and Cowdery type B bodies are seen, but I have told you the two most predominant conditions in which Cowdery type A bodies are seen, which are HSV and VZV, and Cowdery type B the most predominantly are seen in polio and cytomegalovirus virus conditions. However, they are also seen in other diseases as well. But these are the two most predominant areas of Cowdery type A and Cowdery type B bodies. Another difference to tell you was, Cowdery type A bodies were granular, they had granules in them, and Cowdery type B bodies, they were mainly amorphous. So what can we see inside this? We can see that these granular areas are depicting Cowdery type A bodies. What else is seen here? In fact, what do we find here are, we have these certain modified epithelial cells. You can see the normal epithelium here was squarish, but then when the virus had infected it, it had swollen. When it had swollen, it had distorted and changed its shape. The cellular shape changes, and these cells are called as Zank cells. So how much do we have to remember in histopathology when we are talking about the HSV virus? The first thing was, when they are degraded, this is the ballooning degeneration, and in them we had these eosinophilic bodies, which was the second thing which I had talked about was the Lipschutz bodies. The third thing which I had talked about was the Cowdery type A bodies, which is seen, and the fourth hallmark here which I have talked about are the Zank cells. Now again, the Zank cells are not very specific to the HSV. The Zank cells are also seen in multiple conditions. In fact, the Zank cells are seen in other viral conditions, and sometimes they are also seen in certain bacterial conditions as well. So they are not very specific, but yes, we can actually do these tests just to make sure that the disease is herpes. Now sometimes what happens, another stain is used for detecting herpes, which is called as Papanicolaou stain. Okay, the stain which is used here is called as the Papanicolaou stain. Okay, so this generally is also used for herpes. This Papanicolaou can also be used for detecting varicella as well. Okay, so this was mainly about the HSV1 which we were talking about. Now if we talk about, some more things, Sometimes what happens, we have talked about, the primary infection. What was the primary infection of HSV? Okay, HSV had primary infection. Sometimes there can be a secondary infection. The primary infection was acute herpetic gingivostomatitis. Yeah, that was that. Sometimes there is the reactivation of this virus. The virus travels down and it can result in the reactivation or secondary conditions. Sometimes this can be seen on the lips. So you can see plenty of vesicles here on the lips. In fact, we have magnified here so that you can see multiple vesicles are present here on the lip. So this herpes of the lips can happen, which is a secondary infection, which is the reactivation of virus, and this is called as herpes labialis. Yes, this is generally a secondary infection. Sometimes because of the reactivation of the virus, there can be herpes of the fingers. We can see there herpes of the fingers, and this is called as herpetic whitlow. And herpetic whitlow is generally seen in the dentists, because the dentists, most of them are inserting their fingers. Sometimes they don't even wear gloves and they're inserting the fingers in the oral cavities of other patients. So they have these rapid infections and reactivations of herpes, which can be your herpetic whitlow. Okay, so the second condition of reactivation is herpetic whitlow. The first one I had talked about was herpes labialis. Sometimes there can be another herpes which is called as herpes gladiatorum. And as the name suggests, it was found in gladiators. Gladiators were not wearing clothes. They only used to wear those gauntlets or the small underwears. Their whole complete body was open and they used to hug each other tightly and fight and all grapple, do all those things. So if they had herpes on their skin, that herpes was transferred to the other gladiator, and this in olden times was called as herpes gladiatorum. Nowadays this has a modern name as well, which is called as scrum pox. Okay, and scrum pox is seen in players, athletes, those who are doing wrestling, those who are playing rugby or other kind of contact sports. In those people we can have this problem of scrum pox. So we have seen the reactivation conditions could be there, because we were talking about HSV1. So this would be above the abdomen. We've talked about herpes labialis. On the fingers we've talked about herpetic whitlow, and we have talked about herpetic gladiatorum, which is also called as scrum pox. Okay, now if we talk about HSV2, this was all about herpes simplex virus 1. Now when we are going to talk about HSV2, then this is going to affect predominantly those areas which are below the waist, right? So those areas which are below the waist would be affected by HSV2, and that happens predominantly through sexual contact. Okay, right? So oral lesions, HSV1, and through sexual contact we have HSV2, and that virus goes and remains latent in the lumbosacral region, and that is the herpes which is below the waist. In fact, nowadays because of altered sexual activity, sometimes HSV1 can be seen below the abdomen and HSV2 can be seen above the abdomen as well. Okay, so just to summarize the herpes virus 1 and herpes virus 2, we have a beautiful illustration here which talks about, if I have missed anything, we'll cover it in this table. That's why I've included here. So what we see here is that herpes virus family is a large family. This virus is also large. It's a double-stranded DNA. Which ones? The herpes virus 1 and 2. And they are vulnerable to acids, detergents and drying. So these generally thrive in moist areas. That's why they are going to thrive in the oral cavity, and that's why they are going to thrive in those areas which have moistness. Okay, so then what happens is, you see this virus is generally entering here, and when it is entering here, it starts replication at the entry site here. Then what happens, the natural killer and helper cells can initially limit the infection, and that's why the initial infection is asymptomatic in most of the patients. Then what happens, this virus travels down to the nerve and remains latent for a while because it has retrograde traveled into the neuron. It has made the neuron or the ganglia its home, and it is sitting and living there nicely. Okay, we'll see the reactivation when I'm going to talk about the varicella in detail anyways. So hold it here. We have this latent infection, and then when there is some immune suppression, some stress, there is reactivation of the virus. It can travel back to the site of infection, and we have some vesicles which contain fluid, and that is how it infects. Okay, how can be the transmission? Transmission is with close contact secretions. We have vesicles in the oral cavity, sometimes we have vaginal secretions, and sometimes there is vertical transmission as well. That means from mother to the fetus, but that is very, very rare. There is no vaccine for this. Okay, right? How do we prevent it? We can give an antiviral which is called as acyclovir, and we can wear gloves. Why can we wear gloves? To prevent herpetic vitiligo, and we should use sexual hygiene, condoms and all we should wear, and that's how the disease the HSV2 would not spread. Now if we talk about the HSV1 and 2, both types can cause oral as well as genital lesions. HSV1, as I've already talked, typically transmitted orally and infects via the breaks in the skin and saliva, commonly in children. Okay, HSV2 is typically transmitted sexually, genitalia it is affecting, and HSV2 also is present as a co-infection with HIV as well. If we talk about the symptoms here, these are generally asymptomatic, but then in the oral cavity they can have painful benign lesions. Sometimes it can affect the eyes, resulting in keratoconjunctivitis. Okay, it affects the children, then neurological problems results because it's a part of torch infections. Torch infections we'll cover in detail as I'm continuing with this lecture. Okay, and those people who are immunosuppressed, in these people this infection can also happen, and sometimes there can be swelling of the brain as well. This virus can travel into the brain, resulting in encephalitis. So this was a brief summary or a recap of the HSV1 and 2, and next we are moving forward and we are going to talk about varicella, which is HSV3. If you remember, for 3, 4, 5 we had written an acronym which was VEC. V is HSV3, which is the varicella zoster virus. So varicella zoster virus is that member of the herpes simplex virus 3 family, and it is extremely contagious. Okay, this basically you have again 2 infections here. If we talk about the varicella, we are going to have 2 infections here. The first one is going to be the primary infection, and the primary infection is called as chickenpox. Okay, right? So in these people, who knows, if you have not had a shot, then maybe you would have suffered from chickenpox when you were young. Okay, sometimes what happens, there is reactivation of this virus and a secondary infection can result, which is called as herpes zoster. Now this must be a eureka moment for you, and now you would never ever confuse the herpes simplex 1 and 2 with herpes zoster, because herpes zoster is nothing but the reactivation of the varicella virus resulting in a secondary infection. Always remember, the HSV3 has 2 infections. The first is a primary infection, which is chickenpox, and the secondary infection here is that of herpes zoster. Okay, so now the secondary infection again is going to happen because of the latency, which we will talk about in detail now. Okay, if we talk about the etiology here, so this virus generally spreads through air droplets and through contact as well. That means somebody who is already suffering from varicella or is already having this chickenpox goes and meets another person, this virus would easily say hello and would have a new host and would transmit into the new person. And generally this primary infection here is seen, chickenpox, the primary infection is seen in the ages of 5 to 9 years. Okay, so this is how it's happening, and generally what happens is it begins as malaise, the person is tired as the passage is through the pharynx, so you'll have pharyngitis, rhinitis, and in older children we'll have additional symptoms as well, which is headache, nausea, myalgia, vomiting as well. So rash, basically what happens, begins on the trunk. It's a truncal rash. Okay, why? I will tell you how to differentiate it from measles. Measles generally starts from the head, and imagine you've put some paint and it starts dripping from the head onto your body. That is how measles spreads. This is different. The rash here of the varicella starts from the trunk, okay, and then this is followed by the head and followed by the extremities. So this basically rash, this rash is actually your centripetal rash, spreading from the center to the peripheries. Got it? It is spreading from the truncal areas, then it would go to the extremities, then it would travel to the face. And then what happens, these lesions, when they are spreading, travel rapidly, okay, and these lesions, with them you would associate erythema, vesicle, pustule and a hardened crust as well. You can see these red rashes, these vesicles here have these fluid filled center areas, right? So what happens, you have a fluid filled area in the center, and on the margins you have this red area. Okay, so this appearance is also called as dewdrops on a rose petal. What is this called? This is called dewdrops on a rose petal. So you've seen the red roses and you've seen their petals. Just imagine a dewdrop has fallen onto it, and this classically looks like that. Okay, always remember this rash is called as, because it has this red margination here and a central fluid filled vesicle, this is called as dewdrops on a rose petal. Okay, so sometimes what happens, this redness basically arrives and may extend up to 7 days as well. Okay, right? So this rash, when does it start? This basically starts 2 days roughly around the initial problem started, and then when this rash appears, it later on starts to crust. Okay, this fluid dries up. This fluid filled vesicle, when the fluid has filled, now it dries up. You can see these areas are drying up. When they are drying up, now this drying up area is called as a scab, and this scab later on falls off. Okay, so this scab later on falls off.